Okay, I'm going to give an overview of our paper characteristics and treatment pathways in pediatric and adult hidradenitis suppurativa, an examination using real-world data. This was published in the Journal of the American Academy of Dermatology in May of this year, and the link will be accessible to get the paper if you desire. So the motivation for our work is that there's limited research examining real-world data to elucidate treatment patterns in pediatric and adult HS patients. Our study leveraged 3 large real-world databases to understand the characteristics and patterns, and our overall objective was to evaluate the treatment patterns and characteristics of these patients. So there's a lot of background on this slide, and I'm not going to go through all of it, but we'll just start with the most obvious part of it, and that's the picture itself. The picture is trying to illustrate that it causes small inflamed nodules that can become very large and swollen, and they can sometimes rupture and be very unpleasant. So the takeaways are from this slide that HS is a chronic and recurring inflammatory skin disease. It usually occurs in the 2nd or 3rd decade of life. It can be associated with significant comorbidities, those that are listed here. Some of them are mental health related and can cause higher rates of suicide, et cetera, in those patients. Recently, from 2015, maybe not so recently, some biological therapies have been approved to treat HS patients. And so one of the things that we were interested in our study was to see if we could actually see those therapies being used and sort of get a sense of what that looked like. So to date, there's been very few adequately powered studies that looked at biologics in HS patients and looked at adult and pediatric patients. So we feel that this work fills a knowledge gap by giving some details of these treatment practices and comparing children and adults. So our methods, we use 3 observational databases converted to the OMOP CDM. Some of them you may have heard of before, CCAE, Clinformatics, and Medicaid. One of the big differences between Clinformatics and CCAE is that it includes claims from subjects with Medicare supplemental insurance and thus doesn't have an upper age threshold. So we get a broader sense of the population. Medicaid contains claims from subjects that are primarily composed of women and children. The phenotype that we're using is incident HS subjects. They were required to have 2 HS codes. The first code is the index. The second code is in the 31 to 365 days after the first one. The PPV in our data sources was quite high, and we've actually published a paper on this, and that's accessible here if you'd like to review it at a later time. We required subjects to have 365 days of continuous observation prior to the HS diagnosis. We obviously split the population by pediatric and adult age groups at the age of 18. We use Atlas to generate the cohorts and conduct the characterization and the treatment pathway analysis. You can read here at another time what treatments were included in each of the different treatment categories that we evaluated. And lastly, we used cohort diagnostics to look at incidence rates and some other details of this population. So the results, there's a lot of detail here, and I'm not necessarily going to go through all of it, but these are tables, directly abstracted from the paper. Basically, on the left side of your screen is a prevalence table. And the takeaway from that is that the prevalence rates are 2 to 4 times higher in adults than in pediatric populations. And among the pediatric females, the rates were approximately 5 to 8 times higher than in the pediatric males. So that's really all I wanted to say about the left table for now. The right table gives selected characteristics of the adult and pediatric HS subjects. And I've tried to box in red sort of the takeaways that I'm going to talk about right now. And that's that predominantly subjects are female. You could see the percentages ranged from roughly 78% to about 85%. So it's very female heavy burden of disease. You can also see that amongst the pediatric age group, the age group 12 to 17 was the highest proportion of subjects identified. The comorbid conditions we evaluated required 1 single diagnosis code, and that was done intentionally to maximize our sensitivity to capture these conditions. We also evaluated these conditions in the 30 days prior to 180 days post-index. You can see that let's start with the top. Obesity was more common in adults than in the children. And then we can see that diseases such as type 2 diabetes, depression, and anxiety was more common in adults than in children. You can see that acne was more common in the children, which is not surprising given that's more of a teenage type disease. All right, so let's go to the treatment pathways. So on the left side of the screen, the very colorful pictures, that's our actual treatment pathways. And on the right side is a table, which gives you a sense of the percentage of first-line treatments for adult and pediatric subjects by database. But I think the main takeaways here is that for those of you who are maybe not so familiar with treatment pathways, the most inner circle of those circular plots, that represents the first line of treatment. And then from there out is the second, third, fourth, et cetera, lines of treatment. You can see that we've blocked the treatment categories by color. So some of the things to take away from these plots are that when you compare the adult and pediatric populations, there's not a ton of different differences in terms of the treatments themselves. We also recall that we were talking about whether we could see biologics in this analysis, and you could see that the green represents biologics, and there's very little biologic use across this population. So it's something that we're not seeing at the moment, and we therefore won't see whether there's any improvement in outcome based on those drugs being utilized. So it may be something for a future analysis to evaluate. We can see that basically in adults and children's, adult and children, the use of surgical and biologics is infrequent, and in children it's even more infrequent. So just to wrap it up, as far as our takeaways from this study, the treatment patterns are similar in children and adults with HS. HS is much more prevalent amongst females compared to males. Among the HS patients, access to biologic treatments is low. And increasing, we felt that one of the takeaways that the dermatologists had from the study was that increasing HS patients' access to dermatologists would increase access to biologics and may improve outcomes. So as a recommendation for a future study, as additional biologic use data becomes available, it may be prudent to do a reanalysis to see the impact of those treatment decisions and their potential outcomes. Thank you. Thank you to my collaborators.